Hello everyone. We are the residents at University of South Florida presenting a case of CMV encephalitis in a patient with hemophagocytic lymphohistiocytosis or HLH. HLH is a condition characterized by excessive immune activation and may present with CNS involvement. This case describes cytomegalovirus as an etiology for encephalitis along with reactivation of HLH. The infrequency with which both are encountered has left some lacunae in standardized treatment options. This is about a 44-year-old man who presented to the clinic with altered mental status for the past 2 weeks. He has a significant past medical history of HLH secondary to Hodgkin's lymphoma in remission. He was recently initiated on voriconazole and valganciclovir following a diagnosis of aspergillus and CMV pneumonia seen as a pulmonary nodule on PET-CT 3 months back. The valganciclovir was discontinued the previous month due to neutropenia, which resolved with filgrastim, and as the CMV load decreased from 3 million to less than 300 in the blood. His mental status was getting progressively worse with difficulty recalling family members, and he was also complaining of intermittent fevers and chills. On admission, patient was hemodynamically stable and the exam was remarkable as the patient was oriented only to self. Labs significant for pancytopenia but was stable from prior. On admission, the voriconazole was discontinued. Serum voriconazole and CYP2 C19 levels were found to be normal. Patient underwent an LP and showed the meningoencephalitis panel positive for CMV. The cytology did not reveal any lymphoma or hemophagocytic cells. CMV PCR levels were sent from LP and blood, and the CSF viral load was 23,149 and the blood levels of 502. This prompted treatment with IV ganciclovir, but the hospital admission was complicated by persistent fevers. The ferritin elevated from 5,201 on admission to 46,753. The CD25 was elevated at 3,604 and triglycerides at 366. He was concomitantly treated with dexamethasone and etoposide, but there was no change in the neurological status after 2 weeks. The repeat MRI showed changes in the mesial left and right temporal lobes and EEG showing diffuse background slowing. These are indicative of infectious and autoimmune encephalitis. The paraneoplastic and autoimmune encephalitis panel came back negative. Ganciclovir was changed to postcarnet as the resistance studies came back indeterminate. Due to the poor prognosis, family proceeded with hospice care. HLH is a hyperinflammatory immune response syndrome, and it might be secondary to malignancies like Hodgkin's lymphoma, viral infections like EBV, HIV, and CMV. The diagnosis is usually made by the 2004 criteria, and our patient met 6 out of the 8 criteria. And based on the H score of 208, the probability of having HLH was 92.45%. The prognosis of HLH is very poor with a mortality ranging between 20 to 88%. The treatment is usually done by the HLH94 protocol with etoposide and dexamethasone. The newer lines of treatment with anakinra, tocilizumab, alemtuzumab, and plasmapheresis are found to be beneficial based on the interleukin levels and interferons. In this particular case, we find that the CMV encephalitis is the cause for the reactivation of HLH. The treatment of CMV encephalitis based on the past studies in HIV with CMV is usually done by with foscarnet and ganciclovir, and it is transitioned later on to a monotherapy based on the resistance study. This case illustrates the need for CMV PCR levels from CSF and serum to rule out false positive. CMV infection and filgrastim has both been implicated in initiating a cytokine storm and reactivation of HLH, and it should be used with caution in patients with HLH. IVIG and steroids have been used in individual cases of CMV encephalitis once the patient's autoimmune encephalitis panel came back positive or if there were features of CMV vasculitis. Kindly contact us if you have any more questions. Thank you and have a good day.